The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to be talking to Dr. Rajiv Iyer from the Department of Pediatric Neurosurgery at Primary Children's and the University of Utah. Welcome back.
Thank you so much for having me back.
Did I get that introduction right? Is that where you're part of both those institutions, right?
Yes, that's correct. That's correct.
That's a good thing. So as a New Yorker, how do you feel about pineapple on pizza? Is it an abomination, or should people be free to do whatever they want?
People should feel free, but don't talk to me about it.
Don't ask, don't tell. Is that what you say? All right. Duly noted. Do you believe in other types of pizza besides a New York pizza?
Yeah, absolutely. Deep dish, Chicago,
Detroit style.
I'm all for any pizza, pie pizzeria, all that stuff. And if you guys have any suggestions for good pizza, please let me know.
Yeah, you have his email address from last week. We'll repeat that this week because neurosurgeons work, I think, harder than most people I know. And so you got to be fueled.
We eat big dinners, I think, across the board.
That's a good thing. Last week we talked about spina bifida. This week we want to talk about tethered cord, which is A, I think, a fascinating topic, but B, as I was doing a little groundwork for this and looking at some of your past presentations, there is some kind of fascinating stuff happening in the realm of tethered cord, if I'm not mistaken.
I think you're right. And this is an area that I'm really passionate about, and an area that has come a long way, and we've understood a good amount, but we need to really improve it. And so that's why I'm excited to be in the early phases of my career, because it's going to be something that's going to be really exciting to work on. And so embracing all the, I should say, different techniques used to treat tethered cord, I think is important in terms of the surgical armamentarium, but more importantly, studying things from a patient perspective is going to be critical in moving the needle, because patient perspective is the most important thing. This is a truly varied topic. Truly, if spina bifida wasn't varied enough, tethered cord is going to be a little bit more so, because there's so many different types and there's so many different considerations. There's sort of simpler tethered cords, there's more complex. When do you intervene, and what age, and all of these things? What symptoms do you look for? And some of them are out of our space, to be honest. As a neurosurgeon, I'm not an expert in urological issues, but I have to sort of use that data to help guide decisions. But most importantly, I want to hear from my patients about what they're experiencing and if we have made a difference when we've intervened.
And there are more approaches to this. And look, I'm a general pediatrician. I don't see this on a daily basis, but there are more approaches to this than I thought there were. It's fascinating.
Yes. Yeah.
Before we forge ahead too far, have you developed any conflicts that you'd like to disclose?
No conflicts of interest. No, nothing to disclose.
Okay. So define for us what tethered cord syndrome is.
Sure. It's really important to know that tethered cord syndrome is a clinical diagnosis. So there are various tethering pathologies that you see on an MRI, whether there's a patient with myelomeningocele, whether they have a fatty phylum, whether they have a dermal sinus tract, whether they've had previous tumor surgery and now have arachnoiditis, and now their nerve roots are all scarred in and tethered. There are so many different flavors of tethering pathologies, but the common theme is the symptoms that they can lead to. And that's what tethered cord syndrome is. It's a truly clinical diagnosis. So some of the symptoms that can occur, you can get back pain, and that's sometimes just low back pain or achiness. Sometimes it's tearing back pain when kids and adults bend forward, they're stretching their spine, and sometimes that leads to worse symptoms. Leg pain, even radicular pain, especially in the anterior thighs or posterior thighs. Numbness. So basically neurological issues in the lower extremities, as well as other things like urological issues. So that can manifest as a neurogenic bladder. And so in Children who catheterize, do clean intermittent catheterization, it might be that they're leaking in between catheterizations, or that their bladder pressures have gone up and we've detected it on urodynamic testing, or they get frequent urinary tract infections. Other things like bowel function, constipation, or incontinence is possible, leg spasms, spasticity, and then deformities, right? So one of the things that I think is really interesting to think about and study is scoliosis. So many neurosurgeons believe that scoliosis is a symptom of tethered spinal cord. That doesn't mean that every patient with AIS has tethered cord, obviously, but if you have tethered cord, then you could definitely have scoliosis. And I mean a rapidly progressive scoliosis.
We're going to talk about that at greater length next week, so brace yourself. You know, it's interesting because you as a neurosurgeon kind of live in the world of my nightmares. You know, is this headache a Chiari malformation? Is this low back pain a tethered cord syndrome?
Yeah.
I mean, all those things, you know, is this constipation more than just constipation? And so part of what we hope to achieve here is, when should I worry, and when should I just worry? Because there's no choice besides those two things.
Well, I think that there's no great answer except for that any alarming neurological symptoms obviously warrants further investigation, right? So low back pain can be caused by many things. I think our population of adolescents, especially post-COVID, who are hunched over Zoom screens and a little bit less active, but that's changing, I think, are not taking care of our spines as much. And so low back pain is a real issue. But what if it's low back pain that's described as shooting up and down the spine? That's a little different. That's unusual.
Sure.
That's like a Lermite sign. Or what about pain that's associated with numbness? Or if on your physical evaluation you detected hyperreflexia, right? And so, these are some of the subtleties that help us to detect some of these tethered cord pathologies. Like it's all basically called occult spinal dysraphism.
And these may present at different times in a person's life, right?
Yeah, I think that for the most part, we're detecting a lot of this in the very young because you and your colleagues are so great at detecting a lot of this stuff, like a sacral dimple, you know exactly what to look for. And if there's any doubt, you know who to send them to. And we're happy to see all of them and help to screen that. And there's better screening tools. Ultrasound has become more impressive. It's not perfect, but it's a good screening tool, like we mentioned last week. And MRI has come a long way in the safety of MRI. With you don't necessarily have to have general anesthesia. You could just do a swaddle sometimes and do a very focused rapid MRI and detect tethering pathologies. And so with the advent of all these things and a gradual sort of inching forward in the field, I think that we're detecting things earlier. But having said that, let's look at a patient with myelomeningocele who we did a repair. We talked about that last week, an infant who's born with a body wall defect that we then repair. We have to follow that child through their life for tethered cord, right? Because the concept would be that their spinal cord is sort of scarred in. It's very low down in their back, and that does not change. And so when we get an MRI at 1 year of life, they're going to look tethered. If we get that same MRI at 5 years of life, they're going to look exactly the same. They're going to look tethered on a picture. But in phases of rapid growth, especially the adolescent years, that's when we start to see that about 20 to 25% of kids with myelomeningocele who are repaired postnatally start to get symptoms. And so that's sort of the classic picture of tethered cord, right? Is that patient who had a myelo repaired, and then in their adolescent years, because they go through a growth spurt or they grow linearly between the age of 5 and 10, and we detect this stuff. That's why they come to our clinic and see a neurosurgeon. It's not to come in and give us a high five every year. It's to detect this and to try to see how things are going so we can detect things early, because the earlier you detect things and intervene, we think that symptoms are more reversible and you avoid more serious symptoms.
So let me clarify that again for you, because I think you said something that was extremely interesting there, and that's that this is not purely a radiographic diagnosis. This is a functional diagnosis.
That's right. So if someone sent me a picture of an MRI with a low-lying spinal cord, I can say, yeah, it looks tethered, but that doesn't necessarily mean that that patient needs an operation. It's
Now,
all based on how their symptoms are doing.
so in someone who I'm not following otherwise, so somebody who doesn't have a repaired myelomeningocele, what sorts of things should I be listening for in history and looking for in physical exam, especially because, some of these are going to be quite young patients.
Yeah.
What should I be especially sensitive to?
Yeah, especially how they're walking. Children should be able to run and develop normally. Any change in motor milestones that gets you concerned has me concerned and
Mhm.
probably warrants further investigation. Now, there's numerous things that can cause that. One of them being tethered cord. That doesn't mean everybody's tethered, but trouble walking or if their feet are turning, right? Recurrent equinovarus deformities, we've seen that before, or pes cavus, where their feet have high arches to them. So someone who's failed clubfoot treatment, things like that, is sort of a unique example where is it neurogenic in nature is really what we're trying to ask. And then back pain that's occurring with motion and activity, and leg pain that's occurring with motion and activity, especially in young children. Young children don't complain about back pain. So we need to really make sure we're ruling out alarming things if they're having, nighttime back pain, or, they're not participating as they normally would with other kids their age. They're not running, and they were a year ago, for example, a big change from their baseline. These are all things to consider. The thing that's sort of a little bit more opaque is the bedwetting, right? And incontinence,
Mhm.
because there's a big social component, big behavioral component. And so some people out there, neurosurgeons, it's a really controversial topic in our field, going back to sort of the fatty phylum topic, is if you just have a strand of fat in your phylum, which is the piece of connective tissue that connects your spinal cord to the bottom of your thecal sac or bottom of your spine, if that's sort of not that thick, but a little bit abnormal with some fat in it, the question in our field is should you go in and cut that phylum, right? And this, owes to the topic of occult tethered cord, where you have pretty normal findings on an MRI, but the symptoms are really consistent with tethered cord. That's a really controversial topic in our field. And so bedwetting is one of those controversial things, that incontinence, there's so many other factors. So I don't hang my hat on that symptom alone, is the main point.
And then we're probably talking more about secondary aneurysys than primary aneurysys.
Yeah, I think so. And whether there's a neurological etiology.
Yeah. So, put you on the spot here a little bit. What proportion of kids who have tethered cord and back pain are likely to have that exacerbated by stretching? So, by having them bend over or
Yeah.
stretching the lower extremities, how helpful is that?
There's no screening tool for that, and it's really just anecdotal, but it's something I'm trying to hone in on as I see more and more patients with tethered cord. What exactly are the symptoms that you have that another child with back pain or myelomeningocele doesn't have who's not tethered? And
Mhm.
I do think that stretching sometimes, when you have it and you have that finding, I think it increases the sensitivity, I guess, or specificity of picking something up, and it
Okay.
fits the picture. But that doesn't mean that every child who has back pain, necessarily warrants a Adams forward bend test. And if they have pain with that, it's going to be the reason is tethered cord, because there's other reasons like pars defects and
Sure.
scoliosis, and so it's not exactly a very specific symptom.
Okay. So, say that you've decided that someone's tethered cord is symptomatic. What are you going to do about that? Because there are more options than I ever thought before.
Yes. So, really there's not many medicines that I think help with
Mhm.
tethered spinal cord. Sometimes we try gabapentin or maybe a short course of steroids, but I don't know that there's been great success with those things. We're talking about spinal cord dysfunction. What's going on is that the spinal cord is on undue tension. There's too much tension on the spinal cord. And they did studies several decades ago in cats and humans. It was a little bit out there, but I'm glad they did them because we understand them more. We understand this process more. Is that what's going on? What's awry is oxidative metabolism within the spinal cord. And it's stretched, the little capillaries and blood flow into the spinal cord are less. So it's basically living in a hypoxic environment. And so the neurons and glia in the spinal cord are unhappy. And what I tell families is that that stretch and that unhappiness is manifesting as the symptoms of tethered cord, right? It's your spinal cord basically yelling at you. And so our goal in surgery is to alleviate that tension. And there's different ways to do that. And it depends on the type of tethered cord you have, whether we can really realistically accomplish that or not. And so for a straightforward case, let's take that example of what's called a fatty phylum. I've mentioned that a couple of times. It's basically, again, that piece of connective tissue is called the phylum terminale. It's the thing that keeps your spinal cord afloat, but sort of in check in your spinal sac. And it attaches the termination of your spinal cord, which is called the conus medullaris. It attaches that to the bottom of your spine. And so the belief is that if it's sort of thicker than a certain amount, people say 2 millimeters, but I don't necessarily believe a certain number indicates this. Say it is though, and it's thicker, then there's more tension on the spinal cord. So what we can do, if their patient has a lower lying conus and a fatty phylum and symptoms, you're on pretty solid ground to recommend a surgery. And the surgery typically entails a small incision where we remove the posterior arch of bone called the lamina. So it's called a laminectomy or laminotomy. Expose the thecal sac or dura and use an operating microscope oftentimes to open the thecal sac. Use a nerve stimulator to stimulate normal nerves so I know I have a positive control on both sides. And then identify this fatty strand that's sitting in there called the fatty phylum. Isolate it, stimulate it to make sure it doesn't have any normal function to it, and transect a piece of it. And a lot of times what we see is that we have one particular coned in field of view in the microscope and the opening in the dura. And when we cut that phylum, it snaps back like a rubber band out of sight. And so we need to make sure it's not bleeding before we do that. Otherwise, you can get bleeding that's out of sight, right? But we look for that snap. And there's no way for me to detect. It's really an indication of how much tension was on the spinal cord, how much that snapback occurs like a rubber band. But there's no way for me to tell that on an MRI alone, except for some indirect measures like what level is the conus at. If it's lower than normal, again, normal being, well, not again, but to state, normal is around T12 to L2. So if you have a spinal cord termination at L3 and a fatty phylum, plus or minus a symptom, you're on pretty good grounds to do surgery and may help that patient, either as a prophylactic measure to prevent symptoms of tethered cord or as a reactive measure to treat symptoms. The most simple version.
Does that also apply to a patient who, say, has had surgery for myelomeningocele and may have some tethering because of scarring?
It's a very different operation. And so there's gradations in sort of the level of complexity and our level of need underneath the operating microscope. The fatty phylum surgery, we can typically counsel our patients that that's going to take about an hour and you're going to spend probably a night in the hospital. Mm-hmm. The myelomeningocele scar tissue is a little bit different because we're dealing directly with the spinal cord and we have to release it from its adhesions. And it takes a lot longer, usually. It's a little more complicated. And their dura, the thecal sac, is oftentimes thinner, scarred, a little more deficient. So the risk is higher. And so our threshold to do the surgery in a patient with myelomeningocele who's been previously repaired might be a little bit higher. A twinge of back pain is not going to necessarily prompt us to do a tethered cord operation because we have to be able to justify the risks. And the benefits of doing the surgery need to outweigh the risks. And that's why it's a shared decision. And that's why oftentimes we have multiple conversations with families over the course of time to see how are your symptoms doing? Did they go away? Okay, then we're great. Did they get worse? That's a problem because I don't really think of myelomeningocele to be a progressive neurological disorder. The two-hit hypothesis would suggest that most of your issues have already occurred. But a child who's 5 years old with spina bifida myelomeningocele is going downhill, not walking as well, now having UTIs, leaking in between catheterizations. That's a conversation about we should consider doing something. Really hones in on why this is a clinical diagnosis and why education is so important, not just for us and for you guys, but for as the pediatrics community, but also parents, because they're on the front lines. They're with their children every day. They know them best. Mom knows best, dad knows best, family knows best because they're with them every day and they may be able to detect these changes over time, but they need to know what to detect. So many times our conversations start with a conversation like this and talking about the symptoms. He can't walk the length of a football field, or, we're having more issues with our MACE flushes, or, he's had a couple UTIs in the past year. And these are all sort of things that to jog our thoughts about whether tethered cord is happening in order to sort of build a case, so to speak, about whether the surgery is worth it.
It sounds like the implications are slightly different too, because fatty phylum surgery It's something that sounds like it's an anatomic variant that you treat and hope to relieve that. In the case of scarring, it would seem to me that you're going into an area where there may be scarring, and the way that you go into that is to perform surgery. And so the implication of that would seem to be that the tethered cord release may not be a one-time thing, that it
You're
may be
absolutely right. You're
multiple.
absolutely right for both conditions. And so actually there is a rate of recurrent tethered cord with fatty phylum surgery. It's hard to know the exact rate, maybe 5 to 10% over the course of 10 years or so, but that's real. And so when we go in and do the surgery, it's our body's natural instinct to create scar tissue and heal what we've done.
Mhm.
And so that's called arachnoiditis. And so when we go in, and even if it's the simplest of operations, we have to be pretty justified in doing that operation because it's not for free. We can't just treat it as a prophylactic surgery and do everybody, but you have to have a certain threshold because there's a downhill risk of about that 5 to 10% of retethering.
Mhm.
And for myelomeningocele, it's a really big issue because some neurosurgeons out there would say if you do a tethered cord surgery on myelomeningocele patient, you're just setting the clock for the next time that they get tethered, right? And so you might say, well, if they reach the adult years, you're good to go, right? Because they're not growing anymore. But that's not the case because there is a concept of adult tethered cord as well, right? And so maybe that has to do with scar contraction, increased scar formation, whatever it is. And so we have this concept where we go back in the field, and it's kind of frustrating for surgeon and patient, right? Because we go back in and do these surgeries and release more scar tissue, but each surgery becomes harder, riskier, more chance of a CSF leak, and that becomes problematic. Sometimes it's like playing whack-a-mole.
So tell me about spinal column shortening as an alternative.
Yeah. This is sort of what people proposed as maybe, you know, the definition of insanity is to do the same thing over and over again, expect a different result, right?
Uh-huh.
Although some pediatric neurosurgeons would say that's what we do, that's our lives, because we deal with shunts and we're always dealing with shunts. But we think about tethered cord a little bit differently.
Mhm.
So if a patient's had multiple untethering surgeries, and especially if they're really hard, right? And so that's what's useful about being in a busy place is that myself and my partners in our practice of 5 pediatric neurosurgeons, if we know that a previous untethering surgery was really hard, whether there's a lipomyelonmeningocele with fat stuck everywhere, it's almost like gum is stuck in your hair. Except the treatment of gum stuck in your hair is to maybe cut out your hair. But we can't do that with myelomeningocele and lipomyelonmeningocele because that's your nerve roots and spinal cord we're talking about. So we spend hours tediously dissecting these nerves and spinal cord and trying to do a good job, but it's not always perfect. And it's fraught with complications sometimes. And so this alternative surgery I think is a really elegant way of thinking about things because it's almost like you have your spinal cord is stretched out like a piece of rubber band,
Yeah.
and you can release what's holding it down at the bottom and allow the rubber band to snap back, so to speak, or at least to give it some laxity. Or you can decrease the distance between the two ends of the rubber band. And so we're not going to decrease the distance between your brain and your spinal cord, but we could remove a vertebra and actually, like Candy Crush, remove a block and then let the tower collapse, so to speak. And that what that does is by shortening the spine and not dealing with the spinal cord at all, you can give the spinal cord, which is housed within your spine, more laxity or
Mhm.
slack.
Mhm.
And actually, we have demonstrated this. This is a newer operation. It's been in vogue for probably the last, I would say, decade or 15 years.
Right.
And I was really excited to bring this technique to this institution, at least our pediatric institution, and do several of these operations called a spinal column shortening, where we do a surgery that avoids the area of spina bifida. We avoid the previous scar and the thin dura and the spinal cord and the arachnoid, and the risk of neurological injury goes way down because we're not manipulating the spinal cord directly. We're going away from the spinal cord and we're
That's
removing it.
fascinating. So you can go geographically to a different area and you're not fighting
Yes,
through the scars. Oh, fascinating.
correct. And so we typically will remove the majority of a low thoracic vertebra, typically T12 or maybe L1. We choose that area specifically because we're removing a block and we don't want to create any iatrogenic malalignment of the spine, right? So we have to think about our deformity principles, and it's of no use if I throw someone's whole body off and I remove a vertebra and I give their spinal cord more slack, but I give them a forward kyphotic pitch and their head is 10 centimeters in front of their pelvis. That's of no use. So we specifically target the thoracolumbar junction, which is a relatively straight area of the spine. And we use different techniques, keep the spinal cord safe, work around the spinal cord, remove a vertebra, and use screws and rods to actually perform a fusion surgery. And we use the screws and rods to reduce the height of the spine. And so that's called a spinal column shortening. And it's a really fascinating surgery. And we've had some good success with that. We had a chance to write an editorial about this surgery here between myself and Dr. Brockmeyer, another pediatric neurosurgeon here who's been around for a while, and really looking at the national data and whether it's worth doing this surgery. It sounds like a huge surgery, right? And It's really scary for most families to hear about it. Right. And not every pediatric neurosurgeon will do it. Not every center will do it. And so we're fortunate to have this technique here. And I think we're continuing to advance the craft and keep it safe and try to iteratively increase the safety and efficacy of this surgery. And also to do it in the right patient, right? If you've had a fatty phylum and you have some scar tissue, we can go back in and release the scar tissue. But if you have a spinal cord that we know is super stuck and you've been given a neurological deficit from your last surgery, this might be a reasonable alternative. Or the patients with lipomas or fat balls that are stuck to their spinal cord. This is a great way to just avoid all that stuff and reduce the height of the spinal column and give the spinal cord a little bit more slack and pulsatility, which improves the blood flow into the spinal cord and reduces the symptoms of tethered cord.
And are these generally patients who are at full growth?
Yes, generally speaking. Some out there are dabbling in very early childhood. We haven't really ventured into that because the question becomes, what's the durability of the surgery, right? And so we're generally focused on the adolescents for this.
Okay. So it sounds like some of the high points that we ought to be remembering about tethered cord are, first of all, that we ought to know what the risk factors are. And above all, that there's so much of this that is clinical and supervisory. So there's always an advantage in this one, especially if we know someone's at risk, of collaborating with someone like you, especially if there's a multidisciplinary clinic like you've got up there.
Absolutely. I agree.
Yeah. Well, that's terrific. Anything else you want to share about tethered cord syndrome? You could probably go on for a week and a half.
I think we've covered the highlights.
Okay.
In terms of, it's a clinical entity. If there's any concerns, send them our way. We're happy to evaluate them. That you're never fully in the clear, that even as your children kind of grow up and start to reach older adolescent years and even transition years into early adulthood, that's a key patient population that can get lost in the shuffle a little bit. But sometimes we detect this in that patient population because they're trying to become more independent, whether they move out, you go to college, get a job. This is sometimes where we see that they're trying to integrate into the real world and it's becoming more and more difficult and challenging.
Well, terrific. Thank you so much for your time today. There's a lot of interesting stuff here. I'm sure there'll be questions. Please send your questions to questions@vcurb.com and we'll deal with those in a couple of weeks. As we mentioned earlier in this episode, next week we're going to talk a little bit about the intersection of tethered cord and scoliosis. Fascinating topic and something that you're uniquely qualified to talk about since you did fellowships in both pediatric neurosurgery and scoliosis and in orthopedic issues.
Absolutely. I look forward to talking about it more, and thank you for having me today.
We'll talk to you again next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.